our next presenter. His name is Dr. Muktar Gadanya. Muktar Gadanya is a partner at ISIC Consulting. He's a public health specialist with over 14 years experience working in health system strengthening and development. He's also on the Ethics Review Board of Marie Stopes International. So now I will let him speak about the experiences of responding to COVID-19 in Nigeria and also talking about some of the issues around gender mainstreaming.
Thank you so much, Amy Lomo, and thanks so much. I found insightful the presentation by Maria and Jurgen, and I hope I'm going to build on some of the issues they said. And the topic for my presentations today is mainstreaming gender in COVID-19 response, drawing lessons from Nigeria. As Amy said, my name is Dr. Muktar Gadanya. I'm part of the IC Consulting. And this is a brief outline about how my presentation is going to progress. I'm going to briefly talk about COVID-19 epidemiology in Nigeria as it relates to gender, including showing how COVID-19 affects men most, but affects women most. So the contrast, infection men, affectation women, and then I'm going to briefly discuss lessons about gender mainstreaming for COVID-19 in Nigeria, especially the health system response. And this is going to be very brief for those who don't know Nigeria, an West African country, a population of over 200 million. That's about 3 times the population of the United Kingdom and about 60% of the population of the United States, with population density per kilometer in the range of 300 to 400 persons per square kilometer, which is variable between regions. And then we are neighbors to largely Francophone countries, Niger, Chad, Cameroon, Benin, and Togo. And in terms of brief gender epidemiology for COVID in Nigeria, the data I'm showing are from the midnight of 1st September 2020. So this data has been less than 72 hours old. Diagnosis of 34,522 males, constituting about 64% of all confirmed COVID cases in Nigeria, with about 36% complementary value for females. And as you can see from what looks like a population pyramid, largely an infection in males. So people may argue, if you are mainstreaming, what should be your emphasis? Is it to emphasize on males or females? And we know bulk of the disposition by the male gender relates to hormonal situation. Our data has shown that anti-male hormone drugs like dutasteride and tamsulosin have significant value in reducing males' disposition to COVID. And we know that there's a Gavin phenomena where a US physician was confirmed alopecia from hyperandrogenism, had a severe case of COVID. So most of the vulnerability for males arise from biological and physiological disposition. And in terms of how COVID affects women more globally and in Nigeria, we know in Nigeria, women are making significant contribution to COVID-19 response, not only in Nigeria, in the US, for example. But as Maya said, there are long-standing inequalities, which are now exacerbated by COVID, the pandemic, leading to bigger hit on women arising from the COVID-19 pandemic. We know that in Nigeria and globally, gender-based violence is on the rise, including online violence. And in Nigeria, gender mainstreaming is only now been explicitly articulated in the states and the national response plans, with earlier interventions fragmented and not synergized. So they are now being explicitly captured, gender mainstreaming. Earlier, before now, most of the interventions were by partners and a little intervention by government in a non-synergized and in a fragmented approach. And these interventions relate to hotlines and services for gender-based violence, for survivors of gender-based violence, who may be isolated, who are usually isolated with their abusers, and it becomes more pronounced when people are under lockdown, so that abuse can go on for 24 hours or more than when there is no lockdown, and the abuse probably only goes on in the evening or for when the two partners are around. And there is no, at the moment, there are plans to create COVID-19 specific stimulus plans to build women economic empowerment. Before now, such plans are not existing. In Nigeria, especially in southwestern Nigeria, women are overrepresented in informal work, and they are among those people who tend to have incomes accruing on daily basis. And globally, and this too resonates in Nigeria, we know that with the current disruption to logistics, current disruption to sexual and reproductive health services, it was estimated that about 47 million family planning clients may lose access to modern contraception if the current situation persists for 6 months. And this could result in global 15 million additional unintended pregnancies, and unintended pregnancies potentially leading to unsafe abortions, with implications for maternal morbidity and mortality. And these are data from Nigeria's National Routine Health Management Information System, anchored on the DHIS2, has shown consistent decline for most of the contraceptive commodities, most marked for injectables, which in the first 4 months of the year declined from the uptake decline from what it was in January before COVID became a big issue in Nigeria. It was about 270,000 in January, declining to under 200,000 by end of April, with lower level of decline for implants, the uptake, and then slightly lower level of uptake of IUCDs. This is based on the programming by the health sector, that when outreaches are conducted, still respecting women's sexual and reproductive rights, but then promoting as much as possible long-acting reversible contraceptives, which are going to foster the COVID response and allowing for lower need for healthcare workers' resources. And we saw in Nigeria decline in the capacity of the healthcare system to train healthcare workers on general family planning methods and on delivery of long-acting reversible contraceptives. So compared to the same period last year, January, April in 2019, compared to January, April in the current year, we saw substantial decline in number of providers trained for all kinds of activities related to family planning. Last year, for the same period, over 4,000 healthcare workers trained, but for the current year, only about 300 trained. And for training for long-acting reversible contraceptives, it was about a quarter of what was achieved last year, and in fewer states in the current year than in last year, as you can see from our left side. And what has been the national response to what I described earlier, Nigeria's stakeholders, anchored by the government effort, aim to ensure women don't face more structural inequality due to COVID-19. And there was a realization and effort to implement the following: protection of essential health and support services, especially as they relate to primary health care and sexual and reproductive health services. And the realization and increasing process of operationalization of the need to support and listen to women in the front line, the women who are responding to the epidemic, for example, community-based distributors of contraceptives in Nigeria. And then because of the large engagement of women as a proportion in the informal economic sector and in the daily income category, it was realized that there is need to build women's economic resilience so that they will be able to survive periods, the rainy days periods. And then increasingly the system, as at August and September, is increasingly including women and women's organization in decision making. So getting women and women's organization to contribute to programming as they relate to gender mainstreaming for medical and socio-economic programming, including for the recovery period. And the major lesson learned by the Nigerian stakeholders is to, from the beginning, start mainstreaming for gender, for disability, as Urigen mentioned. From the outset, everyone was panicking. So the response initially was not as holistic as now. Stakeholders are planning to be more inclusive for disability, for gender, for minority status, and for other conditions which would foster for equality and then contribute to a better response and then better containment of COVID in Nigeria. And COVID has been recognized in Nigeria as a big health, developmental, and socio-economic challenge. Nigeria is largely a mono economy, and a lot of people, as I mentioned, women in particular, in the informal sector with daily incomes. So there was a huge disruption to the macro economy and to the micro economy as it relates to the average woman and man on the street. And so this is a summary of my presentation. For people who are willing to read additionally on the issue regarding gender inclusion in Nigeria, this is my bibliography list, largely available online, and for the ones which are not available, if you consult IC Consulting, we are going to be able to supply them. And thank you so much, everyone, for finding time to attend this webinar. And I hope to be able to offer clarifications or requests. Thank you so much, everyone. Back to you, Amy.